everyone, my name is Dr. Cindy Sen, and I am a breast surgeon at Northwell Health. Today, we are going to talk about breast cancer screening, what everyone should know. Breast cancer is the most common cancer among American women. In 2019, there were more than 268,000 new diagnoses of invasive breast cancer and more than 62,000 cases of non-invasive or early-stage breast cancer. Breast cancer makes up approximately a third of all new cancer diagnoses, and 1 in 8 women will develop breast cancer in their lifetime. Breast cancer is the second leading cause of cancer death after lung cancer. The good news is that death rates have been steadily decreasing since the late 80s. The overall 5-year survival for breast cancer is 90%, which is quite high. And in 2019, there were more than 3 million breast cancer survivors in the US. Why do we get breast cancer? We don't really know the cause of most breast cancers. Most likely, it is related to changes in the genetic material, or DNA, in our cells. These changes are often related to our lifestyle, but some can be due to age and other factors, which we'll discuss later on. Why is there more breast cancer? It seems that the number of cases diagnosed has been going up. In 1970, there were 69,000 cases diagnosed. And as I mentioned, in 2019, there are more than 268,000 cases. This is owing to the fact that with better medicine, patients are living longer and thus are getting diagnosed as they get older, but also because of better screening. In the 70s, only approximately 30% of women underwent screening mammography. In the 1980s, this doubled to about 60%. And by 2015, this has gone up to about 72% of women ages 50 to 74 being screened, which is shy of 100%, but still better. Mammography does save lives. Currently, 75% of all breast cancers are detected mammographically. 2/3 of all new breast cancer diagnoses are now either stage 0, non-invasive, or stage 1 or 2 with excellent cure rates. This is important because the stage of diagnosis is related to prognosis. When cancer is caught at stage 0 or 1, when cancer is still localized, this makes up approximately 62% of cancers. The 5-year survival is 99%. Stage 2 or 3, with regional spread of the cancer, this being about 33% of diagnoses, has a 85% 5-year survival. When cancer is caught at stage 4, when the cancer has already spread, making up 6% of diagnoses, the 5-year survival is much lower at 30%. There have been multiple randomized studies that have looked at the value of mammographic screening for early detection of breast cancer. And this has found a reduction in mortality. For women ages 50 and over, that reduction is about 1/3. For younger women, the reduction is less, about 15%, and this is likely due to the difficulty in imaging a younger breast, which is generally more dense. When do we start mammogram screening? It really depends on who you ask. This is from a Kaiser Family Foundation survey asking when women without family history of breast cancer, meaning a woman at average risk, should begin mammography screening. And almost half of women thought that women should start before age 40, which is very young. These are some screening guidelines from various professional societies, all with their own recommendations. I will go over the first two. The first being from the U.S. Preventive Services Task Force. This was published in 2016, and they recommend that women undergo biennial or every 2 years screening mammography for women ages 50 to 74. Starting before age 50 should be an individual decision. They felt that there was not enough evidence to assess any additional benefit or harm to screening mammography in women 75 or older. And they recommend against teaching breast self-examination. These guidelines are in contrast to those given by the American Cancer Society. They recommend that women aged 40 to 44 should have the choice to start annual breast cancer screening with mammograms. Women starting from age 45 to 54 should have annual mammograms. And after 54, from 55 and up, women should have annual or biennial mammograms for as long as the woman is in good health and expected to live 10 years or longer. On the topic of breast self-exam, they note that it is optional, and they stress that it is important to look for any changes, such as new lumps, changes to the nipple, particularly if it's being pulled inward, noticing any discharge from the nipple, any changes to the breast or nipple skin, or dimpling. And they stress a clinical breast exam, which should be conducted by a primary care provider, a OBGYN or a breast surgeon, as part of a health exam. And this should be done every 3 years for young women in their 20s and 30s, and every year for women 40 and over. For high-risk women, and this is defined as women with a family history of breast cancer, notably if they have a first-degree relative, a mother, even a father, male relatives can also have breast cancer, siblings or children. Specifically, if the breast cancer is diagnosed in those who are premenopausal, if they are young with breast cancer, if there are multiple members with breast cancer, and clearly if there is a known genetic predisposition, such as a BRCA1 or 2 mutation. If the patient has a personal history of breast cancer, they would be considered high risk. And also, even without a prior diagnosis of breast cancer, but a breast biopsy that has shown a high-risk marker, such as atypical hyperplasia, also known as atypia, or something known as LCIS, lobular carcinoma in situ. This is somewhat of a misnomer since carcinoma is in the name, but it is not cancer, merely a high-risk marker. For these women, the recommendation is to add an MRI to yearly mammogram. So while mammograms are very helpful, it does have its drawbacks. Cancers can hide in dense breasts. Here we see 4 different mammograms of different densities. In panel A, we see a fatty breast with an arrow pointing to a small cancer, which is easily seen. In panel B, this is a breast with scattered fibroglandular densities, and we see a fairly large tumor there pointed out by an arrow. However, a smaller cancer might hide in one of the densities. In C, this is a heterogeneously dense breast, and we see arrows pointing to a large tumor and a curved arrow pointing out to an involved lymph node, which can clue the radiologist in to what can be hiding in the densities of the breast. In panel D, we see an extremely dense breast, and the arrow is pointing to a large tumor that is also demarcated by a triangle marker, showing that this is a palpable lump. And so having dense breasts is definitely something to be aware of when getting a mammogram, because things may not show as easily. So moving on to lifestyle and breast cancer risk. What can we do to lower our risk of cancer? There's some risk factors that we can't modify, that we cannot change, such as our age, our race, our history of prior breast biopsies, as I mentioned, atypia or LCIS. We can't change our family history. We also can't change our age of menarche or the age of menopause. However, there are risk factors that are modifiable, such as our pregnancy history, lactation, physical activity, maintaining a healthy weight, reducing alcohol intake. Increasing age at first full-term pregnancy has been shown to be related to increasing breast cancer risk, particularly having a child after age 30. This is important because the average age at first birth in the US has been slowly increasing over time. In the 70s, the age was about 21 years old, and in 2019, this has crept up to 27. Another lifestyle risk factor is obesity. particularly postmenopausal obesity, which has been shown to have a 30 to 50% increase in risk. Obesity has been known to be correlated to cancers that are more likely to be node positive, to be more aggressive, to be higher grade, and more likely to be associated with the triple negative breast cancer subtype, which is, again, more aggressive. Studies have shown that increasing physical activity, about 3 to 5 hours per week, can reduce your cancer risk. This is likely related to reducing the level of estrogens and other hormones or growth factors that are known to stimulate cancer growth. Alcohol consumption is also a lifestyle choice that can increase breast cancer risk. It's been shown that increasing levels of alcohol intake are correlated to increasing breast cancer risk. So I counsel my patients that while you don't have to completely abstain from alcohol, it definitely helps to cut down. This slide from the CDC shows that in 2016, female breast cancers make up, for the most part, the largest portion of new alcohol-associated cancers. For high-risk women, if a woman knows that they are at increased risk, say due to family history, there are additional options that she may consider. One, chemoprevention, which is the use of drugs to reduce the risk of breast cancer. This is not to be confused with chemotherapy, which are medications that are given to treat existing breast cancer. And also preventive surgery for women with very high breast cancer risk, usually reserved for those who have a known, say, BRCA1 or 2 mutation. So in summary, I want to stress that it's important to know your risk, to know your family history, and to consider ways that you can reduce your risk. That includes lifestyle choices, maintaining a healthy weight, reducing alcohol intake, considering starting your family earlier if possible, and also breastfeeding. For those at highest risk, there's the option for chemoprevention and also risk-reducing surgery. And most importantly, I want to stress that everyone should go get your screening done and encourage your loved ones to get them done as well. Thank you for your time.